We are live. Hello, good afternoon, everybody. This is Tony Daring of the GoCogno.com, the website for people with mild cognitive impairment, and author of the book, I Want My Mind Back, the GoCogno Approach to Halt or Reverse Mild Cognitive Impairment. This is a Facebook Live for our private Facebook group for people with MCI. And my special guest today is Dr. Michelle Papka, the founder of the Cognitive and Research Center of New Jersey. Welcome. Thanks so much for joining me today.
Oh, thanks for inviting me to join you.
That's great. So, Dr. Papka, would you just take a moment and just tell our viewers a little bit about yourself and your background?
Sure. I'm a neuropsychologist, so I study the relationship between the brain and behavior. And I work both as a clinician, helping to diagnose cognitive disorders and changes or behavioral changes. I work as a therapist. Um, I offer psychoeducational support to people and to families. And I also have a very active clinical research program specific to clinical trials for people with mild cognitive impairment, memory disorders, Alzheimer's disease, or other types of age related cognitive impairment. And I have specialized in this field of cognition and aging for over 25 years now of having a joint clinical and research experience.
And it's a special privilege to have someone of your expertise and knowledge. And so glad to get started. As we get going here, I do want to remind our viewers that the purpose of this discussion is to talk about how to get a proper evaluation and accurate diagnosis of mild cognitive impairment or dementia. And Dr. Papka will be speaking in general terms. She won't be able to address your specific situation, your diagnosis. That can really only be done by reviewing medical history, doing a direct evaluation, and also, just as she speaks in general terms, she won't be addressing like maybe a specific medical condition or issue that you have, although we may be able to have time for some general questions as we get toward the end of the discussion. So as we get started here, let me ask the most basic question. Why is it so important to get a diagnosis of mild cognitive impairment?
Well, there are many reasons why a person may show changes in their cognition. And sometimes well, let me backtrack a little bit. As a result of normal aging, we do have declines in our cognition. So all areas of cognitive functioning decline over the lifespan. And it's important to understand whether the changes we're experiencing, first of all, are a result of normal aging or something else. Um, the other thing is that there are many different things that can cause mild cognitive impairment, and it would be important to understand what is causing someone's mild cognitive impairment so that we can plan the right types of interventions. And what I often find is that when people have mild cognitive impairment, either they may dismiss it or their doctors may dismiss it, or family members may dismiss it. And that's because, by definition, when someone has mild cognitive impairment, they're still functioning. So they may notice that there's something going on, and there may be some objective measure that there's something going on, but they're still basically able to function in their daily roles, which may prevent them or people around them from giving it the attention and the seriousness that it should get, because some types of mild cognitive impairment may be reversible or addressed. And for others, there may be steps that people can take to help moderate future cognitive loss. So for those reasons, it's extremely important.
Okay, so now let's take a scenario. A person goes to the primary care doctor, says, "Doctor, I seem to be having memory problems. I'm not, I'm concerned," and say perhaps the doctor gives them an exam like the MOCA test, for instance. I always like to mention that because it's known to be more sensitive to mild cognitive impairment than some of the other tests, and says, looking at these scores, it's a little out of range here. I need to refer you to further evaluation, and then is going to refer this person to you or someone like you. So then when that person comes to you, talk about what you do to give them a much more thorough evaluation that's going to lead to that accurate diagnosis that we're trying to get them to.
Mhm. So when someone comes to us for a neuropsychological evaluation, we will begin by asking them to fill out a very detailed questionnaire for us to get an idea of their history and what's been going on with them even before they walk in the door. And we will also ask to receive copies of any relevant medical records so that we can review that as well. When they first come in, we ask if they're willing to bring someone else with them, whether it's a family member or friend or someone who knows them well. If they're comfortable doing that, we encourage and welcome it. Some people don't want to do that, and that's okay too. And we spend about 45 minutes to an hour just kind of getting to know the person and understanding what it is that's troubling them, what they're noticing, what they're finding difficulty in, and also getting a good sense of what that person's baseline functioning is. And after that, we will administer to them a battery of tests, much more in depth than the MOCA or the mini mental status exam, which are, good potential screening measures, but are very, cursory. And we will administer a battery of tests so we can see how somebody is functioning across a range of cognitive domains. So that would include things like attention, memory, language skills, um, utilization of visual and spatial information, and executive skills, which are used in things like planning, organizing, being able to think flexibly, and we want to see how people are doing in those domains relative to other people their age. So they should be performing like other people their age across the lifespan, and they should be performing in the same general category that they would have performed prior to noticing any loss. So, for example, if somebody always functioned in a high average range compared to their age group, they should always function in the high average range, whether they're 20, 50, or 90. So they should stay in that same relative spot on the curve. So we will look at that, and then we put all that information together and then have the person come back, and we will go over with them the results of the testing and our impression as to what we may think is going on. And we will put together a list of pretty comprehensive recommendations, anything from a medical recommendation to require additional medical follow-up, resources in the community that may be of help, pieces of literature, whether we're referring them for psychoeducation to get more information. And I usually do those kinds of feedback sessions with a social worker jointly, so we're each kind of adding our own piece. So we take a multidisciplinary approach. The other piece that I want to add here is that we work very closely with neurologists, psychiatrists, and primary care physicians, geriatricians. And because we happen to also be a research site and have access to different types of brain imaging, and other kinds of lab assessments, the other piece of the evaluation is whether it's done um, through us some way or through a collaborating physician, is to potentially get other pieces of information like results of blood work, results of a brain MRI, or a more specialized type of image. So, what we want is to both have an understanding of the cognitive, behavioral, and clinical symptoms. And then we also want to have as many what we call biomarkers, biological information, to see whether those things correlate or support each other in some way to help us arrive at a potential diagnosis.
Okay. And as you talk through that process, one thing I wanted to ask you, among people with MCI, the degree of cognitive testing that goes on is kind of famous for being a little, I don't want to say traumatic, like an ordeal, like
Yeah,
very taxing,
yeah,
very emotional experience. I mean, people get in the group and say, I just got back from my testing and I cried.
right.
So, yeah, it is a really intense period of testing. How do you help people through that? How do you prepare people for that?
Yeah. So that's a great question. So a couple things I will say is the cognitive testing for somebody who has MCI needs to be um, specific and a reliable, valid test battery. But it does not necessarily need to be, several hours long. And as a matter of fact, depending on the suspected cause of cognitive impairment, having undergoing a very long battery of tests may not necessarily be more helpful than having a 45 to 1 hour battery of tests. So that's one thing. And I think that when you go to a specialist who is used to diagnosing these types of cognitive changes, the battery may not be as long as what some people are expecting. So I can tell you in our office, the battery is typically an hour long, maybe 15 minutes longer than that. And then once we look at those results, we may ask the person to come back if we think that we really would need more testing. So more testing is not necessarily um, better unless those additional tests are really needed and going to be used to help in the diagnosis, which sometimes they are, and we do need to do that. So that's the first thing I would say. The second thing is it can be very upsetting uh, at times for people to undergo the testing, um, and sometimes, well, being anxious or feeling excessively worried about cognitive performance interferes with cognitive performance. But then the reverse is true too, particularly in mild cognitive impairment, that um, if you're so worried about cognitive performance, you may not perform well. And if you're experiencing mild cognitive impairment, then you may feel more anxious. So it becomes a very cyclical um, experience where one keeps feeding the other. And when we see that actually in the clinic, it's also a helpful piece of information that we can help address. Because, for example, sometimes somebody who has mild cognitive impairment might really benefit in their day to day life by having a treatment for anxiety, because the anxiety can interfere with cognitive functioning and vice versa.
Mhm.
Um, so that's one piece. The other thing is, we actually do spend a fair amount of time with people before we segue into the testing. And part of that is because we do want to establish a rapport and help them feel comfortable with us. We also explain that they are not likely to get all the questions right, and that they are going to reach points where they find it challenging. And that means that we've given the right tests. Because if everybody comes in and they get everything right and they remember everything we ask them to remember, then we have what we call a ceiling effect, right? We don't, people are not going to get, this is not like taking a test in school where you're looking for 100%. That's not how the tests are designed. And so we try to prep people so that they understand that it's very difficult for them to really have an idea of how well they're doing on the test or not, just based on their performance, because they are going to max out somewhere if we've given the right test. It's very, very rare that somebody would get every single thing. So that's, that's another piece of it to understand. Um, the other thing that I always explain to people is that the tests are being used for us to help figure out what's going on, if something is going on, and to just have some objective measure. So whether a person does well on the test or not well on the test, it doesn't really change um, what's happening with them in their day-to-day life. So they walked in, having certain symptoms or certain concerns, and when they walk out, they're going to have those same symptoms or concerned. It's just that we're gathering information to try to help put that into a context and to develop a plan, right? The whole point of doing this is to help develop a plan. So I try to have people understand that the focus is not on the score of the test. The focus is just, let's get some information. This is just one part of the piece of this puzzle that we need to put together to try to um, help you get to the next place so that we can get a diagnosis and move forward with some types of interventions.
Yeah. Yeah. Now there are specific treatment guidelines for MCI. And one of the most fundamental of those says that if a primary care doctor sees that you're having some kind of cognitive problem that deserves more looking, unless that physician is an expert in cognition, neurology, those areas, and virtually no primary care physicians are, that the person should be referred to a specialist. Kind
Yes.
of my experience, I think what I see and what we see in the group, and we know statistically because of recent research that many people are not being referred to a specialist,
Yes.
and that primary care physician isn't really equipped to give them what you can give them. So, talk a little bit about who the specialists are, what their background is, what type of a specialist this person might be referred to, and if someone is listening and saying, I didn't get any of those things, how do they ask for those things?
Hmm. Those are great questions and things to point out. So one thing that a person could do is specifically ask their primary care physician, or or physician they're seeing, to be referred to a specialist, because it may be that the physician doesn't know anybody, but it may be that they really do, and they have some sort of reluctance or resistance to bringing it up. So that's one thing I would say, that if you do have a physician who you've been going to, who you're comfortable with, there's no harm in asking. We know from some research that has been done that oftentimes primary care physicians and other physicians may feel uncomfortable or not adept at talking about cognitive impairment, either because they're not comfortable making the diagnosis, they don't have enough time, they don't have the resources, and they may not want to bring it up because it may be like opening a can of worms that they then don't have the time, resources, or expertise to follow up on. But if the patient says, look, I'm a little concerned about my memory or my cognition, and I would like to go to a specialist. If you have someone who you would recommend, that would be great. Otherwise, I'll try to find someone on my own, but I would love a referral from you. And that may just give that doctor an opportunity to make the referral. So the first part of your question, though, is, who should you go to? And there are different types of specialists who deal with these issues. So you could go to a neuropsychologist like myself. You could go to a neurologist, whether it's a general neurologist or somebody who specializes in behavioral neurology. So if you do have access to specialists, um, that would be a good place. Geriatricians, I find, tend to be really pretty knowledgeable about cognitive disorders and as people get older. And psychiatrists, particularly a geriatric psychiatrist, would be a good resource. If you have access to a center, so there are centers at different academic medical centers, that's a great place to start, because these diagnoses and evaluations are multidisciplinary. So whether it's done by everybody under the same roof or a network of private people, private practitioners who work together, expect to see multiple different specialists. So people who come see me will see my colleague who's a neurologist, and or will see my colleague who's a geriatric psychiatrist. We're also sending them to an imaging center. So it's not a one-stop shop. So you've gotten a comprehensive evaluation when you've had more than one consultation, appointment, or data point to help diagnose the problem. And sometimes that can be frustrating, right? We all want to just, you want to go in somewhere and then do what you need to do and walk out with a diagnosis. But that's not what will happen in a comprehensive evaluation. We need different pieces of information, different types of specialists, and different types of data to really put it all together, and to study the patient and what's happening with them in order to formulate a diagnosis. Other resources too, in addition to the academic medical centers, private centers, would be to contact, for example, like a local Alzheimer's association. They often do keep lists of local resources. So the Alzheimer's Association and organizations like those tend to be good resources, and also word of mouth. Um, if you have friends who have been experiencing something similar, I think that those could be good resources as well. And Facebook groups like this, and other pieces of information on the internet that you can verify as being credible.
Mhm. I'm hearing a little more than I used to about functional medicine. Do you work with functional practitioners?
Mm-hmm. So I personally am very interested in integrative medicine, which is similar, maybe not exactly the same as functional medicine. And I always, on a personal level, have had a lot of interest in nutrition and exercise and lifestyle factors on cognition. And I'm very happy to see the field move forward to incorporate all these different lifestyle factors and potential interventions to treat disease, and not just cognitive disorders, but all types of disorders. So I attend conferences and read books and try to keep up on the literature in this area. In cognition in particular, there's been a lot of research over the past 10 or 15 years about the role of lifestyle factors and various aspects of integrative medicine. And so I do have colleagues in my geographic location to whom I would refer patients who are interested in that approach, and will provide information about it. And some people might adhere to certain protocols more strictly than others, so it just depends. But uh, I think that it's important to really look at a person and treat a person holistically. And so I think, having access to colleagues and medical centers and other places that subscribe to this type of holistic treatment is really very valuable.
Yeah, thank you. That's very helpful. So, in preparation for this Facebook Live today, I posted a poll in the private MCI group and asked people to indicate what causes or contributors their doctor has told them are factors in their MCI. You and I had a chance to talk a little bit yesterday. I shared the results of that. There's a little more voting, but the results are pretty much the same. And you had interesting thoughts and reactions to a couple things I wanted to introduce into the conversation. So you mentioned anxiety in an earlier question, but one of the categories, and again, these are things that doctors have suggested may be causes or contributors to someone's cognitive issues: depression slash anxiety slash stress. Uh, Far and away was the thing that people responded to more than anything else. And could you share some of the thoughts and reactions you had to that?
Yeah. So one, my initial reaction is, were these people dismissed? So while it is true that anxiety, depression, and other emotional symptoms, stress for sure, can impact cognitive functioning, and not just impact cognitive functioning behaviorally, but actually have cause a physiological change to somebody. So we know that stress is really bad for the brain. So it's not just when we feel stressed, we're overwhelmed and maybe not paying attention and can't remember things. That may be true, but it's also true that having stress over long periods of time, chronic stress, actually causes a physiological change that then can affect our cognition. So those things are very real. And if somebody really is experiencing mild cognitive impairment because of something like stress, anxiety, or depression, then that shouldn't be the end of the conversation. That should be the beginning of a conversation. So, what do we do now? Because we know that we do have ways of treating anxiety. We can work on ways of treating stress. So, if the doctor really believes that that's the cause, what is that doctor proposing or suggesting, or where are they referring the patient to help address those things? That's the first thing. But the second part of it is, I wonder, are some of those doctors just saying, don't worry about it, you're 70, maybe you're just feeling a little bit anxious, in other words, not taking the complaint seriously, not taking the concern seriously. Have they done their due diligence and and either looked into this themselves or referred the patient to somebody who can look into this and take the concern seriously, and then come to the conclusion? Because I've come to that conclusion with patients that maybe it's due to stress, maybe it's just due to anxiety. But have we looked into it to know that that's what it is? Or could we just be dismissing or ignoring something um, because it doesn't seem as urgent, or we're not quite sure how to handle it? So that was sort of my thought about that. the other thing is that cognitive impairment is often multifactorial, meaning it can be due to more than one thing. So somebody could have, I kind of alluded to this before, somebody can have some type of mild cognitive impairment that's due to whatever, some underlying um, disorder, and then develop anxiety or some other symptom, and that symptom is really kind of secondary to some other cause. And then we're never getting to that some other cause if we're just dismissing it as anxiety. So that was my feeling about that overwhelming number of people who were told that this is what was causing their anxiety. I'm okay with it if it was actually evaluated and they came to that conclusion. And then if they did reach that as a, that's the etiology of it, then what? Now what are we doing? Are we treating anxiety? Are we treating stress? Are we doing something to help this person um, change that?
Yeah. Another thing that showed up on the list, and I thought this was interesting because the Lancet Medical Journal in the last couple of years has started releasing this kind of annual list of causes of dementia that are viewed as being preventable. And it's taken the position 40% of cases of dementia could be prevented just based on what we know right now. And it says one of the leading preventable factors is hearing loss. So there were people in my poll who included that. And again, yesterday you had some thoughts about that. I would just love to hear your thoughts about hearing loss and the connection to that at MCI or just cognitive issues.
Yeah. So one of the things we know that happens as people get older is we do have a change in all of our sensory motor functions. So there is can be hearing loss, there could be visual loss, there can be a loss in motor dexterity and motor slowing, including cognitive slowing. So these are all things that when we evaluate a patient, we want to make sure that their hearing and their vision are optimally functioning. And it doesn't necessarily mean we can get it back to perfect. The same is true of visual loss, but it doesn't mean we can get it back to perfect. But we want to make sure that a person is hearing as much as they possibly can, because we may conclude that somebody can't pay attention or they're not remembering things when in fact they never heard it in the first place. And if you think about somebody who has hearing loss and they're sitting, say, at a dinner table in a restaurant with a lot of different people talking, um, they may just completely check out, right? Because they can't really hear the conversation. They may not hear what's going on at another end of the table. And so they may give the impression that they can't follow the conversation, they don't remember the conversation, they have a personality change because they seem more withdrawn. And it may really just be due to hearing. And even when a person wears hearing aids, it can take a long time, unfortunately, to get the right hearing aid. And hearing aids can often um, amplify background noise. So in noisy environments, wearing a hearing aid can make it sometimes even harder for people to hear. And I don't know this firsthand because I don't wear a hearing aid, but I've worked with many people who do, and this is the feedback that I get. So, and I know from working with patients too that unfortunately hearing aids are not covered by insurance. They can be very expensive, and so to keep utilizing different hearing aids can really be cost prohibitive for people. So that's one piece of it. But the other part of it is that there's more research to show that when somebody doesn't hear, that area of the brain, the cortex, um, that helps process auditory information is not stimulated. And when it's not stimulated, that brain circuitry starts to um, kind of disintegrate, for lack of a better way of saying it. And so by continuing not to hear and not correct hearing loss can result in physiological changes in the brain that lead to a dementia. So there's two aspects to hearing loss. One is the first piece of what I said, that if you don't hear things, you're not cognitively processing them, but also that over time, if you're not stimulating your auditory cortex, that can result in physiological changes that then yield a cognitive dementia, so to speak, which is why it's even that much more important to correct whatever you can correct in terms of hearing loss. There's certain types of hearing loss that may not be correctable, just like certain types of visual loss that may not be correctable. But to the extent that we can, we want to um, try to correct those. And that kind of, just in general, when we talk about risk factors for cognitive decline or dementia, some are modifiable, some aren't, right? So things like age, we can't change. Things like genetics, we can't really change. But some things we can modify. And if we can modify those things, like certain lifestyle factors for correcting hearing or correcting vision, then we want to do that, because the more we modify our risk factors, the more we're doing actively to try to help prevent a trajectory of cognitive decline.
Yeah. So there are roughly 1,300 people in this group,
Wow.
and not, only a small percentage of them will participate in a poll. But one of the things that really leapt out to me, we understand by definition, MCI is not a form of dementia, but people who have been diagnosed with MCI are at greater risk for dementia. And we also understand that particularly people with what's called amnestic MCI, where the cognitive deficit is in memory, are viewed as higher risk for Alzheimer's in particular. Interestingly, in this study, of all the people, I mean, in this poll, of all the people in our group, only 3 people said they have a diagnosis of MCI due to Alzheimer's,
Mhm.
which surprised me. And honestly, I don't know what to make of that. Um, is there anything you make of it? What was your reaction to that?
Well, again, it would really depend on how these different diagnoses were arrived at. So, as you know, a certain percentage of people who have mild cognitive impairment, particularly amnestic type, will go on to develop Alzheimer's disease, or really, if they have MCI due to Alzheimer's disease, they already have the underpinnings of Alzheimer's disease. The clinical symptoms just haven't been diagnosed as that yet. Um, so I would say that it's probably a low number in terms of, so I would say that your survey sample is not necessarily representative of what research shows us, but I would also, want to know the method. So if those people actually went through and had a comprehensive evaluation, and this is how the numbers broke down, I would say you have an unusual sample, but I do wonder if not everybody has had a rigorous evaluation to lead to the presumed cause of the etiology. And, the other thing I would add is that with all the research that we have in Alzheimer's disease and other causes of dementia, um, there's really a clinical diagnosis that's based on symptoms, what symptoms are present. And we've used clinical diagnosing, historically, that's how we make these diagnoses. But because of all the research that we have in these areas with things like specialized imaging, even some, blood biomarkers that have not yet been approved but are, being very heavily researched, um, even through the Alzheimer's Association, our diagnosis is really based on neurologically what's happening. And neurologically, what's happening is happening at a microscopic level in the brain that we are more and more able to study and see in a live person. So there's kind of this dichotomy between what's the clinical diagnosis, meaning what are the symptoms the person shows, and what's the underlying neurological cause of those symptoms. And I think that people are at a great advantage now that we're able to tune into more the underpinnings of what may be causing it biologically, so that we can help people have access to potential interventions and to take advantage of our ability to differentiate between those two things. Because you can have, people who have people rarely have exactly the same symptoms, but kind of the same clinical profile, but the underlying reason of that very similar clinical profile could be different,
Mhm.
completely different.
Okay. We're very close to the end of our time here. It's been a great conversation. There were a couple of questions that were pre-submitted, and maybe we can take just a minute to try to answer one of them if you're able to. But one of the members of our group wanted to know what the connection is between weight loss and cognitive impairment. And is there anything that you can say generally about that?
Mhm. So I'm not sure if the context of the question is somebody having lost so much weight that they're underweight or an unhealthy weight, but there are connections between lifestyle factors of eating a poor diet and risk factors for dementia and cognitive decline. There's also a connection between things like diabetes and risk factor for dementia and cognitive decline, and also cerebrovascular disease and diet and exercise. So cerebrovascular disease, meaning the vascular system that runs through our brain, if affected, can result in mild cognitive impairment and can also result in dementia. So there are a lot of connections between eating and exercise behaviors and cognition. And so we know that, people who are overweight and who are eating poor diets, who are at higher risk for cardiological disease and higher risk for diabetes, are also at higher risk for cognitive decline. And for somebody who may have been overweight or maybe not eating well or exercising well, research shows that it's never too late to change. So that, at any age or at any point that a person can commit to a healthier diet, and the Mediterranean diet has been deemed to be pretty brain healthy, and cardiovascular exercise has the capacity to help moderate any sort of cognitive symptoms. So weight loss in the context of somebody who's been overweight and maybe not eating healthfully and exercising would have the potential to have positive effects on somebody with cognitive changes.
Okay. Well, certainly that discussion of diet, nutrition, exercise, and especially it's never too late to start is a fantastic point to wrap up on. Dr. Michelle Papka, thank you so much for joining me today. This has been informative. This has been fascinating. I know people got a lot out of it. This will be archived here. People will be able to continue to watch it. I want to thank you for joining me today. I want to thank our viewers for joining us. I look forward to continuing to see you all in the group. And until then, as always, thanks for being with us today, and be kind to your mind.
Thank you. Thanks so much. It was a pleasure. Thank you very much,
Yep.
Tony, for asking me to
Thank
join.
you.
Bye-bye.
Bye-bye.